Thanks everyone and welcome. I'm really delighted to see so many people here. My job this morning is to begin the meeting to talk about 90-90-90 for children. And I'll start by defining what we mean when we talk about 90-90-90 and include a global update on pediatric HIV care and treatment. And then I'll talk specifically about the 3 90s, testing, treatment, and viral suppression, where we are now, opportunities, innovations, and barriers to progress. And throughout, I'll include some general reflections and considerations. So in October 2014, UNAIDS published a new narrative on HIV treatment and new final ambitious, but what they describe as achievable targets. 90% diagnosed, 90% on treatment, and 90% virally suppressed. So by 2020, 90% of all people living with HIV will know their status. 90% of people diagnosed with HIV infection will receive sustained antiretroviral treatment, and 90% of those on treatment will be virally suppressed. When you do the numbers, that gets you to 73% of all individuals living with HIV should be virally suppressed by 2020. So if we step back and try and apply this to children, we should start with the new numbers. So just this week, UNAIDS published new estimates for people living with HIV, and it's now estimated, let's see if I can, how do I point? Use the mouse. No. Okay. Well, here's 2014, and you can see that it's now estimated that there are 2.6 million children less than the age of 15 living with HIV infection. And this is down from over 3 million that we've been believed were living with HIV over the last several years. So these are revised estimates. It was also estimated that there are 220,000 new pediatric infections in 2014, again, down from previous years. Globally, it's estimated that there are 2.1 million adolescents ages 10 to 19 years of age living with HIV, including perinatally and behaviorally infected, and probably about 750,000 of these are in the age range of 10 to 14. More than half are female, and it was estimated in the last year I could find numbers that there were about 250,000 new HIV infections among 15 to 19-year-olds, 2/3 in young women and girls. And if you look at this slide, you begin to see over the years the contribution to adolescent infection of those with behaviorally acquired disease in light blue and those with perinatal disease in dark blue. You can see more recently the contribution to the adolescent population of perinatally infected children growing into adolescence is increasingly significant. So let's apply the 90-90-90 targets. If we 2.6 million children less than 15 living with HIV, we would need by 2020 to have 2.3 million children diagnosed, 2.1 receiving treatment, and 1.9 virally suppressed. And if you want to include adolescents and you do the math and some subtraction and addition, we're talking about 3.7 million knowing their status, 3.3 receiving ART, and 3.0 virally suppressed. So let's move to testing and get some sense of where we are and what we might do. If we start with the infants, we know that uptake of infant diagnosis has been less than robust, and in 2013, it was estimated that only 42% of exposed infants were tested with some early diagnostic technology. As you can see on this slide, the proportion of children tested ranges dramatically by country. In black, South Africa, Swaziland, Namibia report high rates of testing. And as you go to the other side of the slide in red, some countries have very, very low uptake of infant diagnosis. As an example, in Malawi, where B+ has been in place for quite some time, it's estimated that there are about 15,000 to 16,000 exposed babies per quarter. And using the data from the last national report, of those estimated to be alive and exposed, only about 60% enrolled into care, and 40% were tested with for HIV by the first year of life. If we try and get a sense of knowing your infection status, so among children, what proportion are known to be HIV infected? There are very few data. These are data from the KAIS, or Kenya AIDS Indicator Survey, which was a big project going into people's homes and testing them for HIV, interviewing them and testing those who were positive for viral suppression. And if we look at the pediatric numbers, they tested 3,681 children, found 28 who were positive, so a prevalence of about 0.9%. Of those 28, 11 were previously diagnosed. Of those 11, 8 were on ART, and of those 8, 4 were virologically suppressed, or 50%. And for adolescents, we actually know very, very little. There's an all-in-one campaign around adolescents and HIV, and if you go through their reports, they've developed the Cascade for all of the high prevalence countries. Using Tanzania as an example, they estimate there are about 140,000 youth with HIV, and they actually have no idea of what proportion know their status. So what can we do to improve identification of infants, children, and adolescents with HIV infection? Well, I was saved the trouble of trying to develop a strategy because PEPFAR has published a very nice document outlining strategies for finding more children in support of their ACT activities, trying to get more children on treatment, and have outlined what are probably the major approaches that need to be in place to find more kids. Strengthening early infant diagnosis, testing all children of adults receiving HIV care through facility and home-based testing, testing children and adolescents at clinics taking care of sick children, TB clinics, malnutrition, pediatric wards, testing children in orphan and vulnerable children's services, and in high prevalence settings, testing mothers and children attending immunization or under 5 clinics. So I think we're all familiar with the infant diagnosis cascade, starting with identifying the positive woman and engaging the infant in follow-up care. You have to obtain a sample, currently recommended to be done at 6 weeks. The sample gets transported to the lab. The sample is tested. The results have to get back to the clinic. Then the results have to get back to the family. And if all goes well, you'll rapidly initiate ART for the positive babies. And there are clearly multiple steps in this cascade which provide multiple opportunities for loss to follow-up as well as delays. There have been many innovations that have been put forward to strengthen the early infant diagnosis and care cascade, and I've listed them here. I don't have the time to go through all of the evidence around these and the work that people have been doing, but include birth testing, so moving the time up to birth in addition to 6-week testing, using point-of-care diagnostics, centralized transport schemes, putting SMS printers to get results back to clinics, SMS reminders to get parents back to clinics, appointment systems with active follow-up, and community health workers to help at each step of the cascade. And I'll show you some evidence of a few of these. recently, an innovative online system has been tested at several hospitals in Kenya, and this system is algorithm-based and provides computer alerts for staff, as well as test messaging alerts to mothers. And I think there have been a number of these kinds of systems that are being tested, and in this evaluation, they found, compared with the historical controls in white, in black, really good uptake and evidence of improvement at multiple steps along the infant diagnosis cascade. In Malawi, in the Tingante program, they demonstrated the value of putting community health workers in to do testing and case finding of children. They assigned caseworkers initially throughout the health facility where sick children would be, or where adults received HIV care, and provided facility as well as home-based testing. And then they added the PMT-CT program, where community health workers were assigned to new positive pregnant women, and they followed them throughout the PMT-CT period. And as you could see here with the introduction of the community health worker program, they had a pretty dramatic increase in enrollment of exposed and infected babies, children into HIV care. And then finally, Ferrand and colleagues have been doing some wonderful work in Zimbabwe, identifying adolescents, primarily adolescents with, who've been missed along their lives, most of them with perinatal disease, doing routine testing in primary care settings where they may come for routine or sick care. And have over the last years described what these children look like and the importance of offering routine testing to target this age group. So there are a number of obstacles along the route to the first 90, defining and obtaining consent to test infants, children, and adolescents. That's a whole talk in and of itself. Health worker shortages, capacity, roles, and responsibilities, who's going to test, where, and when, and are there actually test kits around to test? And for those of you who don't follow the Tour de France, this was the obstacle this week when the bikers encountered some cattle crossing the road. So turning to the second 90, trying to ensure treatment for all these children we're going to find. It's currently, in the newest estimates, estimated that 32% of eligible children are receiving antiretroviral treatment, or received it in 2014, compared with 41% of adults, and that's 832,000. Antiretroviral coverage has gone up dramatically over the last decade across all regions of the world, and particularly in sub-Saharan Africa. However, we're still not where we want to be, and going back to the infants and using Malawi again as an example, and mostly because they have great routine data, if you use a transmission rate over the first year of 5%, one would expect about 750 infected babies per quarter. And as you could see here, the majority of infants, which are in the light pink, were missed, so that they only started about 200 children of what would have been estimated of close to 800 on treatment. In a report on the Early Infant Diagnosis Program from Francistown, Botswana, from 2005 to 2012. Our early infant diagnosis was done in about 10,000 children. 202 were identified as HIV infected. Of those 202, 153 families received the results. 123 infants initiated treatment. And at the time of the report, only 82 children were alive and on treatment. We've seen improvements of what children look like, or their clinical and immunologic status at the time of ART initiation, but far too many are still initiating treatment at advanced disease stage. This is an analysis, 4-country analysis from 4 sub-Saharan African countries of status at time of ART initiation over time, including more than 30,000 children. The first slide, the first figure rather, you can see in red that the proportion of children starting treatment with severe immune suppression, or WHO 3-4 in green, has decreased over time, but still more than half of children in 2010 were starting with advanced disease. And if we look at weight, the children starting at a weight per age disease score at less than -3 decreased, but still the median weight for age disease score was still around -2. And access to CD4 testing is still quite limited, particularly at a primary care level. In this analysis from the Lamplight Project and across 3 countries, you can see dark orange available CD4 testing on site, and light orange CD4 by referral. And particularly at the primary care level, you see more light than dark orange, and CD4 testing is not available on site. And then finally, we see high rates of attrition, defined as death and loss to follow-up among children on ART. In this large meta-analysis, I have Rosen and Fox, including multiple cohorts and thousands of children. They were able to estimate a retention of children on ART of 67% at 36 months. So what will it take to reach the second 90? Well, I propose that universal treatment for all infants, children, and adolescents will be key to getting towards this 90 goal. That we have to expand ART access by decentralization, furthering nurse management of ART for children, and probably having to think about community-based ART. And then newborn HIV testing with earlier identification and engagement of infected infants, probably using point-of-care diagnostics. So the argument that I'm going to make around universal testing is the argument of B+. And what we saw with B+ was when we turned to universal treatment, we saw a dramatic increase in, using Malawi as the example, as in the number of sites providing ART to pregnant women, so that you could access ART throughout the country. We also saw the number of pregnant and breastfeeding women starting ART increase dramatically. There's an 8-fold increase in maternal ART initiation with the introduction of B+. And we also saw in the first year of implementation in Malawi, the number of pregnant and breastfeeding women initiating ART increased by 750%. We saw the same thing or very similar findings in multiple countries as B+ was rolled out. In this analysis from the APATH program across 7 countries, you can see each country where there's a dark dot is when B+ was introduced, followed by an upswing in the number of women initiating ART. So I think B+ has been successful, and it's not the panacea, because it simplifies delivery of PMTCT. It reduces steps in the cascade. There's no need for CD4 or clinical staging to initiate treatment. It harmonizes regimens for PMTCT and ART, and it's easily implemented by nurses and non-specialist physicians. And if we look for, I believe that we'll be seeing some data either today, this meeting, or at IAS for Uganda, where they did go to universal treatment for children as an example. But this is in Kenya. Oops. I'm going to go a little over, but I'll speak more quickly. Okay, in children who are 0 to 14 years of age, these are data of ART initiations in our ICAP programs. And when the guidelines changed to include a universal treatment for children between 5 and 10, we saw a rapid upswing in initiations of children, more children, right after the implementation of those guidelines. To expand access for children, we're going to have to decentralize to primary care facilities, enhance healthcare worker capacity, and it will require innovations in service delivery. Newborn testing may lead to more infants starting treatment early. In this study from Rahima Musa in hospital in South Africa, you can see the cascade of PCR testing at 6.6 weeks, the results back at 10 weeks. At 12 weeks, they had the first visit, and ART initiation was generally at about 4 months. So newborn testing has the potential to shift this whole cascade by weeks, if not months. There are clearly obstacles along the road to the second 90. There's a pressing need to engage with the behavioral and psychosocial issues affecting children and families. We need better drugs and formulations for pediatric populations, and we have to address the health worker issues as well as supply chain challenges. And initiation's only the first step in the lifetime of antiretroviral treatment, so we also have to be wary that we don't start all these kids on treatment and then lose them further on down the cascade of treatment. So I'll very briefly talk about viral suppression. What we know about viral suppression in children is that it varies by a lot of different factors: the population, the age, the gender, drug regimen, calendar year. Published rates of viral suppression with first-line ART generally range from 60 to 90%. And I have a number of examples from published studies, mostly using routine program data, that dip a little lower than 70%. In the ARROW study, we saw consistent rates of suppression in this cohort of children who did extremely well clinically, of somewhere around 80%. And in adolescents, I think things are a little less, a little more dismal. And this is our data from the US in the Adolescent Treatment Network. Blue is on treatment, and orange is viral suppression. I won't go through the details of this slide, but you could see across the board rates of viral suppression among perinatally infected youth by the duration that they were aware of their diagnosis were generally less than 40%. So what are the strategies for achieving viral suppression? Well, we need better drugs. More potent, robust, durable, safe, long-acting, fixed-dose regimens. There's a lot of excitement around the integrase inhibitors and long-acting formulations. We also need innovative models of care and approaches to adherence support, and clearly we'll have to address the developmental complexities across their trajectory from infancy through adulthood for the young people, for their families and communities. I'm just going to briefly show two really quick examples as I'm running out of time. These are data from a study on long-acting injectable risperidone compared with oral risperidone. And you can see with the injectable, you had a dramatic decrease in the risk of psychotic exacerbation and relapses compared with the injectable. And more recently, in my favorite source of medical news, Colorado published their results around teenage pregnancy, and were able to equate a very dramatic drop in the birth rate of teenagers that correlated with an increased use of long-acting birth control, free intrauterine devices, free, and implants. And I think we're all very interested in the latte studies, which are studying dual therapy with captegravir long-acting and rilpivirine long-acting injectables that are currently being done in adults. I think everybody's hopeful that this is the first along the way. There are a couple of community models, particularly for adolescents, looking to support adherence and retention and care. And many people, I think, in this room are working on some of these kinds of activities. And also efforts to bolster key family and youth processes. And this is the CHAMP and VUCA program, which uses a cartoon-based curriculum to support families and to bolster communication. The obstacles along this road are pretty much the same as the others. Prolonged duration of drug development is a major obstacle, and generally adherence to chronic daily medication regimens is poor across multiple diseases, so 90% suppression may be somewhat hopeful. And once again, there's a pressing need to engage with the behavioral and psychosocial issues affecting these children and families, particularly disclosure and sexual reproductive health. So in summary, targets are good, but justifiably aspirational. We have done well, I'd say, with other targets, 3 by 5 and the MDGs, and certainly an opportunity to direct attention to pediatric populations, which many of us feel have been somewhat neglected. Achieving 90-90-90 will require focused attention, political will, innovation, and more than a bit of luck. And into the future, however, I just want to shift back. And the best hope for children will be to prevent new infections. We have another target that we've talked about in the past, that elimination target, and we have the tools to achieve it. So Cuba was the first to end mother-to-child transmission of HIV and syphilis, and hopefully we'll see many countries following suit. Thanks and apologies for going over.